everybody. Thank you for joining us for this webinar this evening, and thank you for your time. Last week we were talking about business sustainability for general practice. This week the discussion has been about CBACs, or community-based assessment centres, and this is a good opportunity for us to discuss at PHO level and at DHB level what are the ideas around that, how are they panning out, how do we evolve this space as we move tomorrow into week 4 of lockdown. For those of you who don't know me, my name's Jeff Lowe. I'm a GP in Karori and have been here for about 30 years. I'm also the Chair of General Practice New Zealand and one of the clinical leads of the Healthcare Home Collaborative. At this stage, I'd like to thank the two organising groups for this, General Practice New Zealand and their CEO, Liz Stockley, and also the Healthcare Home Collaborative, and in particular Amajit Maxwell and Scott Emeris for organising this evening. So enough from me. I just want to introduce, we've assembled a panel of very competent speakers tonight. Firstly, we have Dr. Gary Jackson, who is the Director of Public Health at Middlemore Hospital, who will be leading out the presentations. Then we have Dr. Pauline Horrill, who has a general practice background, but also has experience in international pandemic planning, including with Ebola, who is working in CCDHB currently. And we also have Dr. Nigel Millar, who is the Chief Medical Officer from Southern DHB, who perhaps has some of the most experience with CBACs, having worked in Christchurch previously, where they have experience in setting up CBACs. And also for the Southern DHB, they have a very comprehensive plan as to how you move through the stages of CBAC development. Lastly, I want to introduce Dr. Ashley Bloomfield, who needs no introduction. He's the current knight in shining armour. He's leading not only our sector, but he's also leading New Zealand in our charge against COVID virus. So Ashley, you really know you're making it in society when you've got merchandise appearing on the internet with your name and face on it. So Ashley needs no further introduction. So I'll hand you over to the Director General of Health, Ashley Bloomfield.
Well, thanks very much, Jeff, for that kind introduction. I think, and kia ora koutou, everyone, really good to be on the call. And I will be on just for about the first 5 or 10 minutes, and then I've got a few other things to do. But look, just some comments around CBACs. First of all, really to thank all of you in the sector for the work that's gone on, not just in establishing and staffing and running the CBACs, but the adaptations you've made to your own practice to help deliver care to people in this sort of current, very challenging and unprecedented situation we find ourselves in. So the role of CBACs, I think, as envisaged in the pandemic plan, was much more something we might have seen as a feature of moving into what was the manage it phase of the pandemic plan, where you had kind of widespread disease in the community, and so you were deliberately channeling anybody with influenza-like illness symptoms into a CBAC, so away from traditional primary care, partly to keep that separation of people with respiratory illness away from those who were seeking care for other things, but also to have a much more streamlined approach to assessing, managing, and potentially diagnosing people with an influenza-like illness. Now, we've deployed them somewhat differently, and we've had to do a lot of things different with COVID-19 that we hadn't anticipated in the pandemic influenza plan because of the nature of this virus and what we've learned about its epidemiology and what's happened in other countries, of course, over the last few months. So we've moved from that sort of what would have been a keep it out, stamp it out, manage it type approach to what I call an extended keep it out, stamp it out phase. And so we've deployed the CBACs as we've got this first wave of infection to really identify and go hard on identifying any cases out there in the community. And I think particularly over the last couple of weeks, or just over 2 weeks, with that extended case definition. So our CBACs, and we've got now over 70 around the country, have been used, particularly in this lockdown situation where we've been wanting to not have people out and about, and also where general practice has been moving to more virtual consultations, to have a place that's set up and ready and able to assess and, if indicated, swab people to identify any cases of COVID-19. So over the next week or two, I can see that there's be a continued role for CBACs, and some of you might have heard me talking about us, even though our positivity rate from testing is now well under 1%, we want to just keep testing as quite extensively and in a way almost over-testing. And today I described it almost as kind of population-wide sentinel testing to really root out any of these cases that might be lurking out there, and or any potential community transmission that's happening that we don't know about. So I think the CBACs will continue to have an important role over this next couple of weeks. But if, as we hope, we move out of alert level 4 and down to alert level 3 and beyond, and life starts to get back to normal, my sense is that it will be up to each district or area to think about what the role of CBACs is in that ongoing, what I would hope would be a high level of testing to just identify any potential cases of COVID-19. And we may find ourselves in a situation where we're essentially deliberately swabbing a high proportion of people with respiratory symptoms, particularly anyone with an ILI presentation, but even with milder symptoms, to find any cases so that we can rapidly ring fence them and stamp out any cases that might be popping up. So it may well be that in a few weeks' time we don't continue to maintain quite the level of CBAC type penetration we've got at the moment, and more of those people will be being seen in primary care, or indeed regions, district health boards and PHOs may decide in regions to keep them going as a dedicated facility to do that quite high level of testing. So if people are presenting either to Healthline or phoning your practices, and we want to get them swabbed and get a quick turnaround of testing, finding any cases, getting them isolated, contact tracing really rapidly to stamp out any emergent possible cases before they turn into wider clusters, it may well be that that's how they continue. So I guess that's about all I can say. And I don't know if any of you heard Professor Brendan Murphy, who's the Chief Medical Officer in Australia. He presented with the CVD Cabinet Committee yesterday morning, and one of the things he said stuck with me because it's exactly right. Is he was quizzed about well, what's going to happen next in Australia, and as he said, we don't know what's going to happen, and obviously we want to prepare for any eventuality here in New Zealand, but our aim is to get the cases down as low as possible, and to be really confident there isn't undetected community transmission happening before we start to ease the controls. So, Jeff, I hope that's a helpful overview. If there's anything you think I've missed in that, then please let me know.
Thanks, Ashley. I think that's pretty clear, and you've talked about the emergent role of CBACs and where we might go from here. So I think you've set up the conversation that we're going to have this evening really, really well, and given us a clear steer as to how these might evolve and how that might vary from district to district. So that's a really useful message, and thank you very much. And again, thank you for your time, and thank you for the leadership that you've shown, not only to the sector, but all of New Zealand through this time, Ashley.
Thanks, Jeff, and thanks again to everyone who's on the call for the work you're doing. It's hugely appreciated. Cheers.
Great, thanks. So look, we might move into the presentations now, and I'd like to remind you that, so we'll do the 3 presentations and we'll hold questions for after that. Just a reminder, there is a chat function at the bottom of your screen that you can use to ask questions. We have a number of questions already that have come in prior to this meeting that we'll try and get through, but hopefully a number of those questions might be answered through our presentations. So at this point, I'll hand over to Dr. Nigel Millar from Southern DHB. Nigel.
Thank you. I'll just put my screen on. Hopefully you can see that all right. So I'm Nigel Millar, Chief Medical Officer in Southern DHB, also a geriatrician, not a GP, actually a failed GP, I must say. So I'm going to present what we've been thinking about in Southern around CBACs and the evolution of CBACs beyond what Ashley has described and how we came to that. So first of all, I've got to thank the people at Wales South and Southern DHB who've done the work on this. Wendy Finlay, the nurse leader, Jane Wilson, our nurse leader for Southern, Stephen Graham, who's the clinical director for Wales South, Emma McDonough, who's the hard-working project manager, Kyle Ford for the IT, and Andrew Swanson-Dobbs, who's done the leadership for this piece of work, which has been a great privilege to be part of. It goes back actually further to work I did in 2007 in Canterbury for planning for avian influenza, and the CBAC we actually ran in Canterbury that I actually worked in back in 2009, if you remember that. First of all, in the Southern, we decided we needed a clear mission. What are we doing here about the pandemic? So we nailed it down to 6 things: minimize people getting COVID, limit the harm, the red stream, maintain an effective green stream, look after our health community, our staff, support provision for the wider community, and maintain a viable health system for the long term. And they were the fundamental building blocks of what we've done. This is around the red stream and how we see that working. And I'll just work through this a little bit. We thought it was really important to have the idea of community support, making sure we support people at home with COVID, because if we made this into a hospital problem, it would be a problem, because this is a community problem primarily. And we learned this when we planned for avian influenza. When we did the numbers, we see the hospital can never cope with everything. We've got to keep people away from hospital unless they needed hospital care. So the principle was to be able to support people at home and have a self-assessment program, phone assessment, being able to assess people quickly in a CBAC, and then have more in-depth things like a medical assessment process, and then maybe some initial treatment and stabilization, and the ability to connect and transfer into the hospital system at one point. The goal being that most people will enter hospital with COVID or whatever other illness infective illness they had from the CBAC, and not necessarily directly unless they were in extremis, and then a hospital program, but in also to have the capacity to develop a program of intermediate care if we ran out of hospital capacity. So we could find some other ways to care for people, whether we build new hospitals or commandeer buildings or so on for the extreme situation. That was the overall sort of picture we want to create. And this was done in collaboration across the system. So looking at the idea of a red stream, we wanted this principle of supporting people to remain at home, and starting first of all with the testing program. That was our primary starting point, and putting the challenge to the people from Wales South, who took it up very quickly, to be able to test large numbers of people efficiently and safely without the interruptions that would occur if you did them in routine general practice. For example, having to get organized, put on all the PPE, do the assessment, do the swab, and take it all off again. If we did it in one place, we could do it efficiently and effectively. And then have the capacity to build over time the ability to do more in-depth assessment, primarily led by nurses. However, we recognize that when people began to come to a community-based assessment center with COVID, it's very likely they would have chronic health conditions that were getting out of control. So we needed to start building a program to be able to support them, and that would take a medical assessment, experienced GPs being the obvious providers of that. And then as things progressed, if our pandemic grew, the ability to provide a treatment and stabilization capacity to observe people for 4 or 6 hours, to provide oxygen, IV fluids, antibiotics, whatever else we thought was necessary, remembering we might be managing chronic conditions as well as just the COVID. And then the idea of having a welfare process on site, so we can deal with people who can't go home because it's too difficult, not because they're so unwell. So how could we provide alternatives? And having that close relationship with the hospital. And the ultimate sort of black zone, we described it in Canterbury when we first did this work, was the idea that we may be having to provide palliative care for people. So we have a range of options here that we've built up from the very simple end right through to the extreme end when the whole health system begins to run out of capacity. So moving on from that, we developed a stage model that we gave labels to. And this is probably the most useful description we've got that helps understand what we're doing. So stage A is largely where we've got to. We're providing brief assessment and swabbing. And the trigger for that is high volumes of people needing COVID assessment, presenting to general practice and to divert them to a CBAC or a designated practice, which is the same principle. Or we do have still some general practices in rural areas, obviously, providing the care themselves. And then we consider what stage B would be. We move on to acute primary care and urgent medical management for COVID and patient and other conditions. And having the capacity to do that. And we saw that will be increasing, the demand on general, would occur when the demand on general practice increased and things began to get out of hand. And we could see that if people with COVID were at home and their chronic conditions began to deteriorate, again, it would be quite an undertaking for a routine general practice to take them on. The advantage is the GP would know them. Disadvantages, they've got all the difficulties of trying to run a red stream. So to be able to support that, to take the load off general practice, so general practice can focus on maintaining the health and wellness of the people that they know. Now, stage C is when we move on to things getting really difficult, large volumes of presentations of patients, and then we need the capacity to assess patients in more depth, use point of care testing, maybe mobile x-ray, having some observation beds, being able to give IV medications, IV fluids. And this is the point where there's escalating demand on the hospital, and we have to begin to think about managing the stream of patients, and maybe even beginning now to think about rationing hospital care, because we felt it's much better to ration hospital care in a logical place like this that has the capacity to relate to the community, rather than ration it at the hospital, because that creates a really difficult problem of capacity. And when you ration patients to not receive hospital care, how do you manage them? And the final stage will be stage D. And I suppose I put that line in: anything it takes. Is more creative solutions, beginning to support the idea of diversion to and providing care in intermediate care and palliative care. And that's when people begin to get stuck in the CBAC and there's no exit pathway. So that's the model we put together to progress over time. Of course, events have in the short term overtaken us and left us stuck in left us helpfully in stage A. However, we don't know what the future is. I just read the paper from Harvard about the future projections over a number of years, and it looks to me like we better have this thing ready at any time for the next 2 to 5 years. So thank you again to the team in Wellsouth who helped put all this together. It does form a detailed plan, which I think has been sent around to most PHOs, that supports all the details around how this will be provided. So I'll stop there and let someone else take over.
Great. Thanks, Nigel. That's a very comprehensive plan, and thank you for sharing that with us. And let's hope we do stay lean and green within your overall plan. So we'll move on to the next presentation from Gary Jackson, who has done some modelling on COVID. Gary, over to you.
Yeah, thanks, Jeff, and kia ora koutou, everybody. I'll bring up my slides. If I get my technology right. So what I've got here is a presentation that's sort of done for the northern regions around modelling. So it's looking a bit at Ashley's big picture view around how it's all going to play out, really. So essentially, countries are faced with this sort of conundrum about, do you try to prevent COVID going through your population, or do you try to mitigate or sort of flatten the curve, as being the parlance used? New Zealand was pretty, looking at the South Korea situation, it gave you a sense that yes, it is possible to actually firmly control this virus, and there's a number of measures. which I won't have to run through because we've seen them all play out, that you can use to control the virus. And being a sort of an isolated island down at the end of the world, New Zealand's in a better place than most to actually run the strategy. And if we can keep our borders intact, that you could have a prolonged stamp it out phase where you can control the virus. So how are we doing on that? This is the standard epidemic curve that we see. This is up till Monday when I did this, and the numbers have continued to trickle down. If I take out all the cases that have to do with overseas travellers, the curve still looks very strong, a strong drop-off. So that's looking very promising. I just put tagged a couple of dates in this slide. I was particularly interested in the time it took between when the lockdown actually started, when we went to the full level 4 measures on Thursday, the 26th of March. It took about 12 days before you saw a drop in the number of cases. So that's kind of, you could think of that as part of you've got a 5 to 7 day incubation period for the virus. You've got a couple of days of symptoms before somebody goes and gets tested. You've got a day to get the test results back and then a day to report the test. So you can sort of see how the 12 days can build up. But it does mean that when the government, when Ashley is thinking around what are we doing next in terms of level 3 and level 2 measures, that you've got this lag period built in of up to 12 days, 10 to 12 days, where you'll make a move, you'll let workplaces go back, but not schools. I mean, you don't know what the effect of that will be for another sort of 12 days or so. So that's going to be the challenging bit going forward. So as part of the modelling that we did, we tried to look at, had an advantage of lots of other countries were in front of New Zealand in terms of where they were in their journey. And we were particularly interested, we're going back to mid-March now, we were particularly interested in just how much hospital capacity were we actually going to need. So, so that was what we were aiming for. And we were looking at countries like this. So the mild arrow there is pointing to a Singapore line. The moderate was where Australia was up to at that stage. And the severe line was looking at the South Korean model of a bit of an outbreak, but then brought it under control. We deliberately decided we didn't need to model an Italy or a US scenario because we figured that New Zealand was going to have better control than that. Just by way of comparison, this is where the countries are sitting now. And you can see the shorter line is New Zealand tailing off, and all the other lines streaming upwards on this logarithmic graph. It's quite spectacular when you saw some of the countries move from 100 to 1,000 cases in about 6 days. So that exponential growth is what really frightened everybody and sort of achieved why we did some of the public health measures that we did. We've also used Australia as part of our example. We've trailed Australia in terms of how many cases, even when you proportionalise it per capita. It's been quite useful to see how their curve flattened with similar measures that we've been doing. This graph is what the northern region sort of model looked like, with the different scenarios there, the severe scenario, the moderate scenario, mild. So that we had the 3 scenarios originally, working towards the mild scenario, planning for the moderate scenario with contingency planning if things deteriorated. Latterly, we've added what we call an elimination, hopeful scenario, elimination scenario, which is kind of the curve that we seem to be following at the moment. So this is case numbers for the northern region, is this graph. And then we did a similar modelling both for hospital beds occupied and for ICU beds, and both those have hardly come on the chart in terms of hospital view. So really, when the DHBs are thinking around COVID now, the attention's turning from all the frantic hospital planning and freeing up vacancies and making sure you had enough ventilators. Now the spotlight really does turn back onto the community testing, and so general practice and community really is where the action is now to get that curve down. If we're in the high teens of cases now, we'll be in the under 10 next week probably in terms of national cases. So you're going to have small numbers of cases, but we still are going to want that vast array of testing. So every upper respiratory tract infection or every ILI is going to need to be tested. And so how that segues into, not business as usual is the wrong term, but how that becomes a longer term thing than for these CBACs is what is really interesting me. So I'd love to hear the discussion. That's probably enough from me, Jeff.
Great, thanks, Gary. That's really useful, and it's always good to combine the academics with the clinicians and management is how we deal with this. So thank you for bringing the science and epidemiology to our discussion tonight. So lastly, I'll hand over to Pauline Horrill, who actually has had experience with pandemic planning. And so Pauline, I'll hand over to you to talk about your principles of pandemic planning.
Thanks, Jeff. Just a precision there. My experience is with epidemic planning and epidemic response, not particularly with pandemic. So I don't want to be held up as an expert in that domain. So in contrast to all my wonderful speakers here, I don't have a PowerPoint. This is going to feel a bit more like a chat show. Nevertheless, a little bit of levity is always good at this time. And I think Gary sort of ended on a note that I think is quite relevant sort of as a segue, in that we really are at a situation now where we're very early in this virus transmission in New Zealand. There are so many uncertainties. Uncertainty is the air we breathe. And I'd like to share some of my sort of insights based on what I've seen happen in communities. So as you said, Gary, the ball now is very much in the community courts for the time being. So I can reflect a lot on how communities have responded to epidemics for good and worse in different places around the world. And I'll end on some more sort of comments specific to CBACs. I've had the privilege of being able to visit quite a few locally, and they certainly do all operate slightly differently. And sort of in reference to Ashley Bloomfield's commentary, I think that's actually a good thing. I think CBACs can be a tool and we can use them however we like. But first of all, I'd like just to start off that my experience sort of in investigating epidemics and sort of seeing the management process right through to the tail end of the curve, if you like, has definitely made me a realist and a pragmatist. I think modelling is genius. It's very helpful. It's fantastic that this pandemic has brought public health expertise, biostatisticians, primary healthcare physicians, everybody's sort of working together in a way that perhaps we weren't sufficiently prior. But what modelling doesn't tell us is that it's not always the truth, because even though we're not used to being referred to as hosts, we are actually, each of us now, a virus host. And in fact vectors as well, so this kind of propagating epidemic potential, and so it's a very sort of an unusual experience for everybody to be in. But because this is a human disease and we are hosts, then really the solution is human. Now I can't emphasize this enough, because this is no dissimilar to any other epidemic that I've been involved in. And in fact, if you don't get that community buy-in, if you don't look for this virus in all those cracks and shadows of our society where we know inequity exists already, we're going to miss this opportunity to eliminate or manage this. So I do think it's extremely important. What we do in the community is to really consider who our neighbours are, where we work, who we have contacts with, who is somebody to open a conversation with. At best, we might need them very soon. At worst, we won't need them, but we'll know them better. So the community buy-in is really important. Many places where I've worked in, the epidemic response has fallen over because of, for many different reasons, a developing mistrust or disrespect of health facilities, health staff, health planning, feeling not listened to, feeling turned away. And all of these things, we really need to start to reflect on it, that this is bigger than general practice. It's bigger than any of the sort of professional groups, and I really implore you to sort of think a little bit larger at this time in the phase where we're at. We've got a little bit of time to think and to breathe. So, you know, one tiny little thing just perhaps to bear in mind of as well is that when we are protected in our PPE, which rightfully so, you know, how is that viewed by the people that are coming towards our centres? There will be a number of people who are terrified about this, who will really stay away, and we don't want that. We really have to find a new way to be welcoming and a sort of an inviting and comfortable place for people to come to, even if we're dressed like aliens. So sort of in a kind of a segue really to the fact that I think COVID also is not any different to many other diseases. They do kind of, you know, once we believe we've stamped it out, and then up pops a little outbreak or cluster of polio in a community group that has been marginalised for quite some time, or you know, measles, because the vaccination level becomes too low, below a threshold. So I think we need to, when we're looking at CBACs and testing, and I know there's a lot of work now about, well, how do we, what's our next phase of testing? I'd say we need to do and. We need to continue our current sort of testing and these sort of referral processes that have been set up around the country, but we also need to really think hard about some proactive offering of testing into some of the more marginalised parts of our society. And I think primary healthcare, we're primary healthcare specialists. I think we are really well placed to gently find those doors, those openings, and those communities, and find a way to do that and support this sort of fight against COVID. So I'm just referring to my notes because actually just on their note, you know, when I've been travelling around looking at different centres, there are some places that have done that brilliantly. They've really, you know, they've engaged their local churches, their local marae, their sports clubs, their Indian cultural centres. They've really had those conversations already, and I think that, you know, will be helpful now, but actually it will bear fruits down the track as well in terms of how primary healthcare can lead in this space. So if what I'm saying is something that you've already done, please, I'm not trying to preach to you guys. It's just to try and reinforce that, you know, well done. I think you're doing the right thing. If you haven't done it, get a map out. Get your people all around you at a 2 metre distance around your large tea room. Have a look at your community groups and please try and see who you can reach out to and just open those conversations with. So agility is something definitely we're all starting to get pretty good at. Everyone moved pretty quickly to change the way we operate in primary care. That has to continue. So the uncertainty is the air we breathe, I'd say, but nimble is the gymnastics that we have to continue to do. So I think being agile, being able to live with that, I think that's where we need to go. We don't know if there'll be clusters, there'll be resurgences. We don't know enough about this virus. And what we do also need to keep in mind, though, is that kind of constant change, that being agile is really exhausting. And fatigue is one of my other key points just to keep an eye out for. There's a lot of general practice at the moment that are operating in 2 teams. I'd suggest that's a really good way to continue for some time yet. It's not just physical fatigue, it's mental fatigue. People are worried about home, they're worried about family overseas, and don't underestimate it. It's extremely important. Fast forward even 1 month or 3 months living under this kind of pressure and this uncertainty, the public will be having a lot of anxieties as well, but so will the staff. Going back to that point as well, I think you have to be very mindful when you are having, this is a specific CBAC point, when you do start to have crowds sort of in front of your CBACs when lockdown eases off and you may get more walk-ins, you really need to consider not just security but crowd control. It really is a major problem in many places I've seen. We can't perhaps foresee it, but it would only take a crowd of 50 or 100 people with a few people getting angry and frustrated at waiting, and for all your processes around PPE just to fall over. So when we come to CBACs, which is probably my second to last point I want to make, preparation is absolutely vital. The sites that you choose to put them in is really critical. It has to be a site that is known and trusted by as 100% as possible of the community, that it's a place that they feel welcome and comfortable to come to. Remember, we're thinking 3 to 6 months potentially. So for me, it's all about using a CBAC in any which way you like. For me, it's a tool. Maybe we need to come up with a different name. Maybe we need to throw out the sort of the CBAC guidebook and just think, well, what we're really talking about here is additional venues. If we look at our mapping of our zones where we might need to provide a bit of oxygen into our system to fill in some gaps where there might be some high need communities, or to assist practices that don't either have the logistical capability to manage respiratory and non-respiratory pathways for the winter, or they don't have the staffing capabilities. You need to be able to have a site that can just provide that oxygen in the system and be able to step it up or close it down or scale it up or scale it down whenever you want. This really is something that's a struggle to get our heads around, but we can't just sort of decide we don't think we need CBACs now because the curve is starting to come down. I think that would be a terrible mistake. We need to plan for the worst and hope for the best. And the CBAC, if you've got a really good site and you've got the logistics prepared, you can scale it up and down in a modular way, however you like. It could be just testing, or it could be also with clinical triage, or it could be more of the stage B light or stage B all. Just think more sort of nimbly about how we want to use these community-based facilities, with a real emphasis on potentially the marginalised communities that aren't perhaps enrolled in practices or aren't coming and accessing our services. So the final note I just wanted to say is that we've got a bit of time now perhaps to do this preparation. I'd encourage everyone just even to do it on paper. If you really don't feel it's time to commit resources and staff into something, put it on paper, so that if you do in your locality have a large cluster or a surge of cases, you could step up and stand up that facility within 48 to 72 hours without the sort of clamour and stress and panic that we all experienced 3 weeks ago, that you actually have got it in your head what you're going to do. Hope that you don't need it, but it's ready to go on paper. It's all about logistics, having the supplies ready, having the staffing ready, being ready to go. So those are some of my my ramblings. I was sort of started off with a list of 10. I think I whittled it down to perhaps 6 or 7. If any of that's useful, then that's brilliant. But remember, we are all in this together. And we're all hosts to this virus, so we've got to look after ourselves as well. So thanks, Jeff. Happy to clarify any of those points.
Thanks, Pauline, and it's a really useful reminder of some of the values, principles that we need to use in guiding our way through the next few weeks, because we don't know what's ahead, and it's important we remain agile, so really useful. So 3 really useful presentations there, and thank you for those. We'll go into our Q&A session now, and just a reminder that there is a Q&A function at the bottom of the webinar that you can ask questions through. The first question I've got here is, what national consistency is there in terms of guidelines and governance structures around CBACs? And Nigel, I might allow you to have the first go at answering that.
So I'm not aware of a formal national consistency, just a goal when they were set up this time to achieve testing. I think this is something we should work on. CBACs never really flew in H1N1 because they weren't quite necessary, although we ran one in Canterbury, and I think a couple of other places ran them. But I think my experience from them is yes, having a good structure and a good plan. And so that's why we put a lot of work into our plan and made it available as a starting point for people. And maybe this is a really good thing for GPs as a group to take up for the future. So I really think it's the GP-led thing. I've always resisted the idea of having hospital staff working them, because they'll stay in hospital, which is not what we want.
Great, thanks, Nigel. I agree. there isn't a lot of national consistency, but I suppose it's where people go and where people put their plans for other people to share with. I know you've done a lot of work and we've seen your plan has been distributed quite widely. We've done a lot of planning in CCDHB. I do hear in the large national forums, though, that Health Pathways is a place where people are looking to populate these plans so that there is some national consistency. From others, Pauline or Gary, do you have any comments about that specific question?
There's a little bit of consistency across the northern region. It was tried to plan the CBACs across the northern region, but interestingly, each individual site ended up with slightly different, each site has different characteristics and ends up with slightly different ways of working, but they tried to get a reasonable consistency across the region.
Thank you. Look, another theme that's coming through in questions is the question of equity and vulnerable populations. Pauline, I think you've answered a lot of those in your presentation as to how people might reach out to those priority populations. There's also talk about how we develop mobile units to actually reach out. And I know a number of regions have talked about those services as well. Again, somewhere where people can go and seek ideas, I think is a good idea. Pauline, is there anything you want to add to that, or Nigel or Gary, anything you want to say in terms of how do we keep this equitable and make sure we're not just reaching out and testing the worried well here?
I'd just say to advocate, really, if you're aware of particular groups, then advocate through your PHO, make them aware of it.
Yeah, I think it's been encouraging so far in terms of the breadth of testing. If we look at ethnicity rates and so on, that we are getting a reasonable cross-section of the population. But it'll be interesting as the numbers go down, whether that will continue or people will get bored and won't turn up.
I think it's also about accessibility and making it as the simple pathways to get to the CBAC. I'm much in favour of appointment if best, but the idea is if a patient contacts a GP, the health service, the hospital, the ED department, we've got a process to get them to CBAC. So it doesn't matter where they pop up in the health system, we can get them there easily without causing them too much difficulty. There is a role, I think, for mobile testing, because there are people who have difficulties with transport, with children to look after, and maybe for reasons they don't want, ethnicity reasons they don't want to attend. So mobile testing, I think, is something we should develop based out of the CBAC, but available to people who need that particular mode.
Thanks, Nigel. Yeah, so it's about, if we do want an increased number of tests, and I know in CCDHB we're doing about half the number of tests that the lab can handle each day. It's about removing some of those barriers and being a bit proactive about who we reach out to. Thank you for that. Next one, perhaps doing it to you, Nigel, is the differences between testing centres and actually being a CBAC, and what are the roles of GPs and ED as we move from purely testing centres to something more like a true CBAC?
Well, I think the level A CBAC I was talking about is a bit more than testing centre. It needs to be integrated into the health system, not just taking the test and who's next, but taking the test, managing the process. So our CBAC would have daily discussions with the lab on what capacity there is, so they can scale their testing to match. They see all the results. They manage all the negatives, and following people up, contacting people to make the results known, make sure the results go to GPs, have the IT system set up so they can make sure that the information gets pushed through to the right places, back to general practice and so on. So that's, I think, a CBAC model rather than just a place where you go and get a test and then the result pops up somewhere later and gets sent electronically to somebody else. And I'm more in favour of the CBAC because it gives you a visibility, so we know who we can talk to. Every day I can talk to the CBAC team and get an understanding of what's happening out there, what the test volumes are like, what sort of people they're seeing, what difficulties they're having, and we can keep on improving the system.
Thanks, Nigel. Any other comments? Otherwise, Nigel, I might ask you the question, what sort of medical capacity do we need at a CBAC as opposed to a testing centre?
Okay, so just a testing centre, well, you still need something there in terms of experienced nurses. Our CBAC's nurse-based at the moment because it's mainly testing, but we do have a doctor on site. take as part of the team. We've had the odd person who's come in and turned out to be sicker than we expected. You have to be ready for that. We did have a very unfortunate experience in Canterbury around the CBAC when one patient turned up and was ostensibly looked like they had influenza, was managed influenza, and turned out later to have cellulitis and became septic the day later, and unfortunately went to hospital and died. So you can't just guarantee that the person who turns up with a fever has automatically got COVID. So you have to have a capacity to have, you know, that sort of sixth sense when you see somebody and say, this doesn't look like the thing. Of course, it is an advantage when you're seeing patients who are all supposed to have the same condition. Hopefully the person with something unusual would stand out.
Great, thank you. There are some questions coming through about the role of screening asymptomatic patients, particularly in vulnerable groups. Any comments?
Yeah, the trick with this is around the sensitivity of the test. You know, it's not a very sensitive test, so it's only of variable quality in terms of testing asymptomatic patients. I've seen it's being used for some of the public health units as part of their cluster and contact tracing, where they're testing people in the expectation they're about to become symptomatic, to get the isolation working a little bit faster. But generally, it's a bit variable. The one use I can see of it as we get to a low numbers is potentially sort of like a population survey style testing to really see if there are little pockets of asymptomatic transmission happening. They did that in Iceland. It's just been published in the New England Medical Journal, and did find a few cases who were apparently asymptomatic who were sitting out of the community that they didn't know about. So that may be something that we do as a next stage. I can imagine that in a couple of weeks, particularly as our testing capacity, testing system has capacity to do that.
Thanks, Gary. Another question or group of questions is about as we head into winter and more respiratory illness starts to present, what are the role of CBACs and what are the role of general practice? Are we looking to stream all respiratory patients and that risk away from general practice, or do we need to maintain some presence in general practice? Bearing in mind that the people who know the most vulnerable people and their circumstances of living or their comorbidities are actually at general practices, and CBACs are not always located at their general practice. So any comments there? Pauline, do you have any comments on that?
Well, no, not really. I think it's such a sort of regional question, I think, and I'd probably defer to the, infectious disease specialists around that. Clearly, it depends on numbers. I think it's a numbers game. I think if we could all just manage logistically and safely our patients in our existing structures, then so be it. That would be fabulous. But I don't believe that we're there yet. So that's where the role of a community something needs to be set up either within your existing practice or within your community outside of your practice, so that you can really continue to separate out the respiratory or the non-respiratory, or however you need to do that for your community.
Yeah, I certainly think there's going to be, it is going to reach us into winter. We'll still be thinking around, is this patient a COVID patient or not? So I think you are still going to have your red stream, green stream, or some way of organising that. One positive note might be from the lockdown is that the respiratory viruses are much lower in circulation. So if we have a high influenza vaccination rate and a low circulation, it may be that we have less respiratory patients than normal going into winter. But then I'm always an optimist.
I'd say it's a risk management and efficiency problem. Certainly, if you're getting a lot of people with respiratory symptoms and you're going to have to treat everyone as suspected COVID, then it's going to not do much for your general practice. If you've got the occasional one, well, you're probably fine because you've got the time to go through the processes. So it really depends on what's happening on the day or the month. And that's where having a good relationship with the PHO and the CBAC opportunity, so you can close it down for a while and then bring it back when you begin to see an upsurge in respiratory illnesses, because we want to protect primary care, because we don't want general practice has been put out of action by the staff getting COVID, because the risk is if one staff member gets COVID in a general practice and you're working closely together, there's a strong likelihood that other people are going to get it before you realize you've got it. And that's when you'll get the difficulties and your whole practice might close down. So we've got to manage it, and not to mention the potential disastrous effects in GPs and their staff. So we have to be thoughtful about how we put this together. We don't want to be taking risks, but we don't want to be forcing everyone to go down the road to CBAC when it's only one patient a day.
That's right. Look, I think the solution to this is going to be very right down to the granularity of individual practices, I suspect. I mean, Ashley did set us up well and said, some of the high level things we're wanting to achieve, high levels of testing, that we want to test people with minor illnesses. So anything with a runny nose, cough, or a sore throat, we want to test. But he did say that there would be district by district variation as to how this is interpreted and how this is achieved, and how we keep patients and our staff safe. Then he talked about rapidly ring fencing any little outbreaks that we might see, and also rapid contact tracing for those as well. So some of the other questions that we're seeing now is actually, we get into this mode of testing and everything else. How do we actually move out of that and back into general practice as usual? Bearing in mind that general practice as usual will have COVID attached to it, will have a global financial crisis attached to it, and people suffering chronic illness, mental illness as well. How do we actually adopt this into our new normal, or what's going to be our new normal for the next 12 to 18 months? Gary, do you have any comment as to how we might do that, or what might be useful information to guide us?
No, I think this is uncharted territory. I don't think any country's been in this situation before. I guess what I would imagine is that we'll keep that 14-day isolation of anybody coming into the country for quite a while, until there's a good antibody test or something. I could visualize, you used to have a yellow fever vaccination sheet that you brought into a country to show that you were safe. I can imagine you bringing your COVID antibody test to show that you're immune, so therefore, or you're a recent one to show that you're not infected, to allow you to travel again. But no, I've got no sense of where the new normal will end up.
So I think the question was talking about going back to general practice as usual. I'm never in favour of going backwards. So let's go forward to the new general practice, the new usual. And the health professions have valiantly resisted technology. Apart from using it here and there, we haven't really changed the way we work with technology. And I've observed practitioners move from no virtual consultations to a large number in a very short space of time. And the feedback I get is variable, but a lot of feedback saying, well, it's actually quite good. So we're going to learn stuff in this. I learned this in the earthquakes in Canterbury. The same thing, you learn new ways of doing things that you would never have thought of before because you have to, and you suddenly realize they're actually quite useful. So I think we've got to go for the new normal and take the opportunities that are presented to us to try new things, to get through COVID and work out which ones we want to keep for the future.
Totally agree with that, Nigel. Pauline, did you have a comment?
No, yeah, I agree with that. Also, I think there's opportunities in every horrible situation. The only thing I'd just like to reflect on there is that you're right. Although I've just been sort of going on and on about how it's important to prepare for the worst, plan for the best. At the same time, there's a risk of being very linear in our thinking. We've talked and done nothing but COVID for 4 weeks, and then, again, there's a point at which we need to be able to keep both things balanced there, the business as usual, if you like, or the non-communicable diseases, but remain that little bit of capacity within your team. There are some people who love this kind of agile, nimble, they get a bit of a buzz out of it. Keep those people kind of just keeping that capacity on innovation and moving forward, and the emergency stuff going on. But when the numbers start to shift, we have to remember to get out of that linear thinking. in an epidemic context, because then you start to see the numbers of, sadly, of the morbidity and the mortality as well, sort of ramping up behind our backs because we lost our eye on the ball. So just it's a difficult sort of situation to be in general practice. But you know, I really think we're the leaders in this space. There's an opportunity for us to show exactly what we're capable of and work together. It's great. It's fun.
Yeah, look, it has brought a certain energy, and it has removed a lot of the barriers that we thought were there, and a lot of changes happened when the need and the urgency has been there to change our model of care, to keep both patients and our practices safe, and we can learn a lot. One of the things that I mentioned last week in the business sustainability is never waste a good crisis, and I think Christchurch earthquake was an example of that, and this is a good example of that. We do want to take the learning, go forward, adopt them, and move on. There's certainly a lot of enthusiasm nationally to look at what the model of care should look like going forward, and then how you fund that, because the current funding model doesn't incentivise the right behaviours at the moment. Nigel, do you have any comments on secondary, because they're changing as well? I mean, in terms of outpatient appointments being done virtually, any comments you want to make on secondary care?
I would say exactly the same thing. I observed a whole service just say, tomorrow all our consultations will be virtual, and bit the bullet, you know, because when you go into that new sort of practice, you have to learn, and it's slower to begin with, and things go wrong. And I think in the past, people very easily think, oh, it's too hard, and I'll go back to what I know. So it's great seeing people taking that opportunity. We've also seen a big uptake in the use of virtual meetings. So things like this are becoming the norm, and we're getting comfortable with them. We just happened to put in Microsoft Teams as part of 365, and already people are picking that up and beginning to get a different feel about how we can work as teams without all having to meet together frequently. There's downsides to that. We've got to be careful. We want to keep in touch with each other, but certainly looking at different ways of working and seeing how technology can support us to provide really good care in a new way is an essential part of what we should be doing.
Yeah, I think that's right, and I think our patients are learning that they don't have to go and see a person face to face to get good advice. So I think our population are learning different ways of using clinicians as well.
Great, thanks. And look, just leading on from that, and we might wind up soon. Any thoughts on what we might measure, what metrics we might look at in ensuring that we are leading change in the right direction, and also ensuring that we're addressing equity and measuring things and ensuring we are targeting those priority populations?
Well, I'd say it's vitally important we do measure things that we do. Otherwise, the health system only does the things that are measured. So, and we see that quite regularly. If something new idea comes up, we don't measure it, people don't want to do it. So we need to look at the virtual consultation model, whether it's by video, whether it's by email, or whatever. We need to find ways to measure those, and but not count them as an overhead, have them counted as part of the process. And that's the nice thing about using technology. We should be able to capture that information as part of the process so we can understand it and help people see what they're doing and see how they're spending the time and see what they're achieving.
Yeah, good point, Nigel. And I think it's also important we look at patient acceptance and satisfaction from this, particularly for some of those populations who we might think don't take up this sort of technology, but in some cases they surprise us. For example, the elderly or Māori and Pacific. Good. Okay. Amajit or Liz, are there any questions through that we haven't addressed? We might wind up shortly, I think.
Yep, there are a lot of questions that we haven't addressed. What we're going to do is capture these questions and provide some written Q&As tomorrow or the day after. Quite a few of the questions will need to be answered locally, so that may be the answer on some of them. We'll also, with Nigel's permission, circulate the plan for the CBACs from Southland.
Great, thanks, Liz. So, look, we might wind it up there. It's around dinner time for a lot of people now. I just want to say thank you to our presenters, Pauline, Gary, Nigel, for your presentations tonight and your comments. It's been really useful, I'm sure, to everyone who's been online. I also want to thank Liz, Armagit and Scott, who have been behind the scenes for this evening and allowing it to run smoothly. I suppose a little bit of a question about where to from here, and there is enthusiasm for other webinars. Very happy to run those as well. Currently, there are 2 large groups meeting, the PHO clinical leads meeting, and there's also the National CEOs group, who are both meeting regularly, and some of the ideas and discussion that's generated in those does inform what is on top for people. In terms of information from this evening, Armagit from the Healthcare Home Collaborative and Liz from GPNZ are people who you can contact for further information. Lastly, I want to thank everyone for attending tonight and your interest in this. And we are all learning, and we're all learning. Sharing is a good way of learning. So if you do have information that you want or think would be useful to share, please send it the way of Armagit or Liz, and we can perhaps look at Health Pathways as being a national platform that might harbour some of that information. So again, thanks for your attendance. Thanks for the work that you're doing. Good to hear from Ashley this evening. He was very keen to connect with the workforce out there, because we are the foot soldiers who have been called to duty in this time of huge need, and we're going to need to be there for a long time yet. So keep up your good work, and thanks for your attendance this evening. Good night, everyone.